So good afternoon, everyone. Today we have got some questions on neurology that we'd like to discuss. So I'll be putting the questions on the screen. Go through the options and please point out what you think is the correct answer. So this is a question regarding gabapentin. Which of the following statements do you feel is correct? As you may know that gabapentin is one of the anticonvulsants which are quite commonly used. They have also got other use apart from being anticonvulsants. So they are used in neuropathic pains as well. So phenytoin and phenobarbital are another class of anticonvulsants which are commonly used, and they are the ones which are enzyme inducers, the hepatic enzyme inducers, but gabapentin is not. So the answer in this case is that it does not require any dose adjustment in renal diseases. That is why it is quite renal friendly, and you can use it in even end-stage kidney disease patients who are on dialysis without reducing the dose. Unlike other anticonvulsants, if you are using it such as phenytoin or pregabalin or other things like that. Okay. So the next question is: a 69-year-old lady presents to the pain clinic with a 1-year history of gradually increasing pain in her legs, and there is associated weakness as well in both her legs. There is no past medical history. She does not smoke and she does not drink alcohol. Her knee reflexes are reduced. She has a fasting glucose concentration of 116. What is the next best investigation to confirm the plausible diagnosis? Please mind that the question is asking the best possible investigation that you would do in this case. So, what you see in this patient is you basically get a case of bilateral lower limb pain associated with weakness, and the question gives you a clue that the fasting blood glucose levels are slightly high. The range cutoff that they have given is 100, and the patient gives a value of 116. So, this is one of the complications of diabetes which the patient may have had developed, but she did not realize it. And this is what is called as a diabetic amyotrophy. This is more common in elderly diabetics rather than in the young patient population with diabetes. And so, to confirm the diagnosis, you need to subject the patient to a formal oral glucose tolerance test where you give the patient 180 grams of glucose and then again check the value, the blood sugar levels after 2 hours to make a formal diagnosis of diabetes mellitus. So, this is a 58-year-old gentleman who attends the outpatient department with an 8-week history of lethargy, neck pain, weakness in the upper limbs, and gait discomfiture. He describes occasional episodes of electrical sensations shooting down his spine on flexing his neck. He has a long history of lower back pain, primary generalized osteoarthritis, and vitiligo. He takes Voltaren regularly. He neither smokes nor drinks alcohol. He is of Philippine origin and he has been in the UK for the 9 years and denies any recent history of foreign travel. He is afebrile. He, his general examination is normal except for vitiligo. Cranial nerves are normal. There are no wasting of the limbs, and there are few fasciculations in the brachioradialis and the biceps on the left hand side. The tone is mildly increased. There is mild weakness of elbow, wrist, and finger flexion, extension, which is more on the left, but the power is normal. There is inversion of the left supinator, the triceps. The jerks are reduced bilaterally. Sensation is also reduced in the C5 and C6 dermatomes. So first you have to note that the patient is a 58-year-old gentleman, and the X-ray findings, if you note the X-ray of the cervical spine, it is mentioned that there are extensive osteophytes which are obvious. So this is a case of a degenerative cervical cord disease or the degenerative cervical spondylosis. It is a normal degenerative age-related process. Gradually, the percentage of population which gets affected rises as they become older. The joints, the discs, the facet joints, and the ligamentous structures can all be affected by the degenerative changes. Uh, you can have myelopathic features as well as radiculopathic features. There is also a possibility that you may get direct neurological damage or you may get ischemic changes as well. Compression, stretching, and angulation can cause radiculopathy, and compression, ischemia, or recurring minor trauma results in myelopathy. Please note that this does not require cervical collars. This generally requires rest, anti-inflammatories, analgesics, and other supportive treatment, and only in the rare cases where you get extensive neurological deficits do you require surgical intervention. What feature would you expect in a 45-year-old lady who has been diagnosed with dystrophia myotonica? Okay, so this is basically an autosomal dominant condition, generally presents in the 20 to 30 years age group, and the features which commonly are included in this symptoms complex is cataracts, ptosis, you may get frontal baldness, gynecomastia, diabetes, and you may have reduced reflexes with myotonia. The general presentation is weakness with myotonia. A 69-year-old lady with a 4-month history of tremor affecting her right arm presents to the neuro clinic for evaluation. A past medical history is that she suffers from a depressive psychosis for 8 years, for which she has received intermittent chlorpromazine and amitriptyline, but these have been stopped for the last 6 months. She has three sisters who also have tremors. On clinical examination, she has a resting tremor of her right hand. Cogwheel rigidity is present and she has mild generalized bradykinesia. What is the most presumable diagnosis? So this is idiopathic Parkinson's disease. The clue to the diagnosis lies in the question that the signs are unilateral and that is how it usually presents. Remember, Parkinson is an asymmetrical disease to begin with. Later on, with the advancement of the neurodegeneration, it can become bilateral, but at time of presentation, it is mostly unilateral. So, as we all know that it is because of the loss of the dopaminergic neurons of the substantia nigra that this is commonly caused. Uh, a very interesting differential which was given was drug-induced Parkinsonism, but remember, chlorpromazine is linked to it, but she has stopped taking the medicine for the last 6 months, but her tremors are still persisting, so it is unlikely to be related to the drug she is taking. There is also a history of uh, three sisters in the family also having uh, these tremors. We do not know what type of tremors they are, so please do not get distracted by that particular information in the question. These tremors of the sisters should also have been described in detail. A 51-year-old gentleman presents to the clinic with loss of sensation over the lateral 3.5 fingers of his left hand, with tenderness of the left forearm and inability to make a tight fist. He complains of pain in the left arm while twisting door handle anticlockwise. Fallon's test and Tinel's test are negative, otherwise, he is neurologically intact. What is the most likely diagnosis? So, this is a pronator teres syndrome. The clues that are given in the question are that the patient reports a loss of sensation of the lateral 3.5 fingers. So that means the median nerve is affected. And once the patient is trying to make a pronator motion of his left forearm, that is twisting the door handles anticlockwise, the pain is getting exacerbated. If you look at the other options, stroke is incorrect because there is involvement of the peripheral nerves and not the central nerves. Diabetic polyneuropathy is incorrect because it is unilateral. You do not get carpal tunnel syndrome, and you have the Fallon's test and the Tinel's test are negative. And multiple sclerosis again is not the correct answer because you have the involvement of a peripheral nerve and not the central nerves. A 71-year-old gentleman with a 10-hour history of unsteady gait of sudden onset, associated with vomiting and headache, following which he has increasing drowsiness, was brought to the emergency department. What is the presumed diagnosis? We can see in the options that there are two very similar options. One is the acute subdural hemorrhage and one is the cerebellar hemorrhage. So it's the general rule where if you have a history which runs in hours, like in this case, it is given that there is only a 10-hour history, then it is mostly a traumatic cause or a vascular cause. And we have two options which are quite similar to each other. So then the differentiating factor is what features the patient is presenting with. Okay. So he gives the question gives a clue that there is unsteady gait. So unsteady gait points to a cerebellar pathology. So this is a case of a cerebellar hemorrhage. So this is a hippus. We are given that the patient is being evaluated for headache. So we might think that this is a pathological sign, but it is not so in this case. Hippus is also a common benign finding which can be present normally without any underlying pathology. It is basically a rhythmic dilation and contraction of the pupil. It can be observed normally but can be exacerbated more if we shine a light into the eyes. It is generally not pathological, but there are some conditions such as aconite poisoning, trauma, cirrhosis, and renal disease, which can also cause pathological hippus. Which of the following is not affected by a lesion of the facial nerve in the internal auditory meatus? This is again a question of neuroanatomy where you have to recall the course of the facial nerve and the various branches which come off from it at its various length. In this particular case, if there is a lesion in the internal auditory meatus, sweating over the cheeks is unaffected, while the rest of the functions of the facial nerve, such as the taste, the blinking, the lacrimation, and the hearing, will remain normal. A 73-year-old lady presents with complaints of weight loss, lower limb weakness, and dry mouth. He has been a heavy smoker for many years. She looks cachectic. She has proximal lower limb weakness, areflexia. There is no wasting or fasciculation, and the sensory exam is normal. Which blood test is most likely to confirm the diagnosis? So, what we are dealing with is basically a case of a Lambert-Eaton syndrome, and Lambert-Eaton syndrome can commonly present as a paraneoplastic syndrome secondary to a lung cancer, which is the likely diagnosis in this patient given her long history of smoking and the fact that she looks cachectic. So the Lambert-Eaton syndrome is shows the presence of the voltage-gated calcium channel antibodies, which is the answer in this case. A 64-year-old lady presents to the clinic with mobility problems. She has Lermite's phenomenon, is Romberg's positive, and a wide-based gait that deteriorates on eye closure. Ankle jerks are absent, and the plantars are extensors. She takes thyroxine, and there are no other medical comorbidities. She is concerned she has an uncle who has developed unsteadiness and ended up in a wheelchair. What is the most likely diagnosis? This is a very good question, and there is a very big red herring that has been given. A supposed family history of an uncle who has developed unsteadiness and he has ended up in a wheelchair. So, a lot of you may be prompted to reply to point to Friedreich's ataxia as the likely answer, but please remember that the age of the patient is 64 years old and it is very unlikely for Friedreich's ataxia to be presenting at that age. The likely cause is the lack of vitamin B12, and the patient has subacute degeneration of the spinal cord. So, uh, all of these features are indication of the involvement of the dorsal column, which leads to the positive Romberg's test. It is causing the white based gait that is seen. And the absence of ankle jerks can also be seen in the following other conditions as well. They are listed over here. So please remember that the question is attempting to throw you off with this supposed family history of the uncle, and do not and always consider the age of the patient as well. An 81-year-old gentleman is admitted to the rehab center following a stroke. On admission, a Barthel index is performed. Which of the following best describes the limitation of using the Barthel index in rehabilitation? So the Barthel index is a scoring system where which is performed to see the level of independence or the level of disability in a patient. So this is a system which consists of many different points, such as whether the patient is able to take care of his bowels or bladders on his own, whether he is able to dress up on his own, whether he is able to shower on his own, whether he is able to eat on his own. So what happens is, uh, this is you do this basically to see whether the patient is improving functionally or whether the patient is deteriorating over the time. So what do you mean by a floor and ceiling effect, which is the correct answer in this case? It basically means that you can have very false, you can have the Barthel index, which can be falsely low in some cases, such as the ones who are for which you are performing the index immediately after a stroke. Although the patient may feel may have the ability to retain some of the functions, but eventually, but he may not be able to do it immediately following a stroke. And the other and the ceiling effect is where even though the patient may score very high on the index, but he may not have complete independence and would be dependent in some form of the other on his caregivers. So while it is a good score to assess patients over a period of time as to whether they are able to attain functionality independence, but it also does tend to have a floor and a ceiling effect. A 23-year-old lady presents to the emergency after punching a door. She has lacerated the medial aspect of her wrist, damaging the ulnar nerve. What is she at risk of developing? This is, I think, first year anatomy question. So the question directly mentions that the ulnar nerve is damaged, and we all know that damage of the ulnar nerve leads to claw hand. So, what is the action mechanism of action of fingolimod? The other agents are the one of the older agents which were being used was the interferon beta 1, and fingolimod is a oral medicine which has been approved. Now we all know that multiple sclerosis is an autoimmune disorder. So all the therapeutics that are designed or intended for use in multiple sclerosis are in some way or another immunomodulator or immunoregulatory drugs. Fingolimod is also the same. Fingolimod basically does its action by inhibiting the ceramide synthetase inhibitor, which what it does is it sequesters the lymphocytes in the lymph nodes and does not let them attack the white matter of the central nervous system, leading to demyelination in multiple sclerosis. It has been seen that use of this drug leads to reduction of the relapse rate in multiple sclerosis by greater than half. Which of the following causes cerebral malaria? So only the Plasmodium falciparum species has the ability to invade the central nervous system by crossing the blood-brain barrier and leading to all those hemorrhages in the brain. And this is responsible for most of the deaths of malaria that is reported around the world. Which of the following is the specific antibody found in neuromyelitis optica? So neuromyelitis optica is again a demyelinating disease which only involves the optic nerve and the spinal cord. It spares the brain, and the antibodies specific to this are produced against aquaporin 4. A 17-year-old girl is admitted after a blackout at the dentist. Her mother describes how she blacked out as the dentist began performing a filling and that she jerked her arms a few times and was then unrestrained. She awoke a minute or so and was oriented and complete, but nauseated. There are no similar episodes in the past, and she is totally unaware of what has happened. Examination is normal, and ECG is normal. What is the presumed diagnosis? So, this is a vasovagal syncope which commonly happens during the dental procedures, and it is usually induced by pain. And the facts in favor are that she has recovered very quickly, and the ECG is normal. There is no history of urinary incontinence or biting of the tongue. What is the characteristic feature of transient global amnesia? So the characteristic feature is that the perception remains normal. So the onset of anterograde amnesia, repetitive questioning characteristic, is what is defined as the transient global amnesia. So patients are usually disoriented in time and place, but they are not disoriented in person. And the perception is retained by the patient. That is to say that the patients themselves recognize that they are disoriented in time and place. There is no neurological deficit that occurs, and this is a rule in transient global amnesia. It usually occurs in middle aged or elderly people, and mostly in the mornings, which lasts about in hours, and they usually recover on their own. Recurrence does not usually happen. 39-year-old gentleman presents to the ophthalmic clinic with an acute history of pain and blurring in his left eye. Examination reveals a visual acuity of 6 by 36 in the left and 6 by 6 in the right eye, a central scotoma in the left eye, and a left swollen optic disc. Which of the following is the most likely diagnosis? The diagnosis in this case is of optic neuritis, and it is the presenting feature of multiple sclerosis. This is the last question of the day. A 51-year-old gentleman presents to the emergency complaining of a severe headache and vomiting for the last 10 hours. He was previously well, takes no regular medicines. His temperature is 99.5, his pulse rate is 105, blood pressure is 98 by 65. There are some neck stiffness, and there is third nerve palsy with pupillary involvement. These are the investigations. Which of the following is the most plausible diagnosis? I'll go back to the investigations again. So this is a case of a pituitary apoplexy. The points in favor are, if you look at the serum sodium levels, it is 122. Potassium is marginally high, 5.2. But the serum random cortisol level is low. TSH is fine. And the serum prolactin levels are also low. So you have a case of a patient who has a headache and vomiting for 10 hours. His blood pressure is low, he has dyselectrolytemia, and his cortisol level is low. So this goes all in favor of pituitary apoplexy. Encephalitis, you wouldn't get dyselectrolytemia so early on, at least. Meningitis, you wouldn't get the hormonal imbalances. Subarachnoid hemorrhage, again, no hormonal imbalance, and migraine obviously does not present like this. Okay, thank you for all for your time.